A 57-year-old woman comes to the physician because of 6 months history of fatigue and shortness of breath in exertion. She feels winded after climbing 2 flights of stairs. She has no serious illness. Menopause occurred 9 years ago. She was receiving hormone replacement therapy but discontinued it 4 years ago because of concern about breast cancer. She does not smoke. Her pulse is 88 per minute. Blood pressure is 130/80. Crackles are heard on the lung base. The remainder of the examination shows no abnormality. Chest X-ray shows interstitial markings but no effusion. Pulmonary function tests show a decreased diffusion capacity, decreased FVC, decreased diffusion capacity, decreased FVC, and increased FEV1 by FVC ratio consistent with restrictive pattern. Which of the following is the most appropriate next step in the diagnosis?
Hmm. Why do we need the next step? They already know she has restrictive pattern that's causing the fibrosis that's causing the shortness of breath. What do what else do they need? Hmm. This is weird. Ready?
Yes.
Hmm. Interstitial lung disease (ILD) refers to a heterogeneous group of disorders that results in pulmonary fibrosis and progressive impaired lung function. There are widely variety of causes, including infections, occupational and environmental exposure, drug-induced pulmonary toxicity, radiation-induced lung injury, connective tissue disorder, hypersensitivity, pneumonitis, idiopathic. Patients classically present with progressive shortness of breath and chronic but not productive cough. Inspiratory crackles and hypertrophic osteoarthropathy may be present on physical exam. Definitive diagnosis require lung biopsy and histologic examination, but this is not always performed as it does not often change management. Typically, the diagnosis is made on the basis of clinical and radiologic findings. High resolution CT of the chest is recommended for all patients to provide diagnostic support. Okay. PFTs is often used to assess and monitor disease severity. ILD is associated with restrictive pattern of spirometry and reduced diffusion capacity caused by inflammation and destruction of the lung parenchyma and alveoli. It's not C because exercise stress and ventilation perfusion lung scans are not commonly used in diagnostic workup or management of ILD. Exercise stress tests can be used to evaluate for coronary artery disease, while ventilation perfusion lung scans are commonly used to evaluate for PE in patients unable to tolerate CT scan. Okay, next.
Okay. 78-year-old man is admitted to the hospital because of 6 weeks history of progressive shortness of breath. He was diagnosed with colon cancer at age 55 years. He has congestive heart failure, MR, and COPD. His medications are lisinopril, latenolol, hydrochlorothiazide, tiotropium, and supplemental oxygen therapy. 2 liters per minute by the nasal cannula. He appears anxious and is severe respiratory distress. He uses accessory muscle of respiration. Temperature is 99, pulse is 111 per minute, respiration is 22 per minute. BP is 134/88, pulse is 2 liters per minute on 2 liters per minute on oxygen by nasal cannula and shows oxygen saturation 86%. A physical examination show mild JVT and hypertrophy. Mild JVT and hypertrophy of the sternocleidomastoid. Pulmonary examination show decreased breath sound. Pulmonary examination should decrease breath sound in the right lower lobe and dullness to percussion. Cardiac examination should discrete 3/6 hollow systolic murmur at the left sternal border. There is 2 plus edema of the lower extremity of the knee. Chest X-ray is seen. Hemoglobin 11, leukocyte 11,000, segmented neutrophil 64%, lymphocyte 24%, monocyte 12%. Serum protein is 5.2, LDH is 230, pleural fluid is 7.38 RBC, WBC, and pleural fluid protein is 1.2, and pleural fluid LDH is 85. Okay, let's do the what uh, lights criteria. Pleural fluid protein divided by serum protein, isn't it?
Mm,
And pleural fluid LDH divided by serum LDH, isn't it?
or is it the opposite? I don't remember. Is that or is that the opposite?
I think that I'm saying right.
Okay.
Pleural
Which are the
fluid protein.
pharmacotherapy? Mm,
Am
so
I
what does
right
he
or
have?
wrong?
Oh, I didn't see. What does he have?
Pleural effusion seen on the X-ray, right-sided pleural effusion.
But okay. So he has a bacterial pleural effusion. So I need
Yes.
to put
This is-
edema
No, it's
and then
not exudative. It's trans. Okay, they are talking about the therapy.
mm,
Cardiac examination through the knees.
edema, ethnocephalic, warfarin. Okay, ready?
Oh, 1 second.
Okay.
Are you thinking about infection?
Isn't it
Yes, I think
or
so
not?
too.
Okay. Nope.
Ah,
It's heart failure, probably. When
according to my yeah, sorry, according to Light's criteria, it is transitive. Even if it is transitive, I
mm,
choose that.
mm,
That
mm. Okay, okay. Pleural effusion occur because of wide variety of underlying conditions. A diagnostic thoracocentesis should be performed whenever the cause of the effusion is unknown. A therapeutic thoracocentesis can be used to relieve clinical symptoms. Any fluid obtained is then analyzed for cell count, organism, pH, glucose, total protein, and enzyme concentration. Pleural effusion are categorized into exudative and transudative effusion based on the Light criteria, which assess three ratios. Whether pleural protein to serum protein is greater than 0.5, pleural LDH to serum LDH is greater than 0.6, or pleural ADH is greater than two-thirds of the upper limit of normal for serum LDH. A single positive criterion defines an exudative fluid. For this patient, the protein ratio is what is it? Protein ratio is to 0.23 because they did what you said they did 1.2 over 5.2.
yes.
Okay, let's see. 1.2 over 5.2. Okay, 0.23. LDH is 0.37 and pleural LDH is 85. Okay. The upper limit of normal serum LDH depends on the specific lab performing the assay. Given that the serum LDH is 230, we can assume that the third criterion is not met. The fluid is identified as transudative effusion. Okay. Which narrows the diagnosis to conditions that increase capillary hydrostatic pressure, or decrease plasma oncotic pressure. The differential includes heart failure, cirrhosis, nephrotic syndrome, This patient with a history of congestive heart failure, mitral or peripheral edema, the most likely diagnosis is heart failure. Exacerbation and the most appropriate initial pharmacotherapy will be diuresis with furosemide. Next, please. Yeah. Next.
Okay. 57 year 57-year-old woman comes to the physician because of 10-month history of serum fatigue. She awakens 4 to 5 times nightly to void. She now takes daily naps and frequently falls asleep while watching television. She has noted swelling of her legs and occasional palpitation during the past 6 months she has not had fever, night sweat or changes in the bowel movement. She has had 18 kg of weight gain during past year. She is 160 centimeter tall, now weighs 145 kg, BMI is 57 kg per meter square, pulse 96, respiration 20 per minute, BP 160 over 90, pulse oximetry on room air shows an oxygen saturation is 92%. An X-ray of the chest show no abnormality. ECG shows sinus tachycardia and P pulmonally. Which of the following is most likely cause of patient nocturia? Picked. Nocturia. Second is oh, okay, okay, I got it. BMI is 57, so it is OSA. Looks like OSA.
Obesity hypoventilation syndrome OHS is the most likely cause of dysphagia nocturia. OHS is occasionally encountered in patients with BMI over 30 and is common in patients with BMI over 50. Chronic alveolar hypoventilation leads to both hypercapnia and hypoxemia. Hypercapnia results in compensatory metabolic alkalosis, which manifests as an increased serum bicarb concentration, while chronic hypoxemia can lead to pulmonary hypertension and polycythemia. When severe resting hypoxemia may be apparent, pulmonary function tests are often done to exclude other causes of hyperventilation and hypercapnia. These studies are frequently normal, although they may disclose varying degrees of restrictive lung disease and reduced diffusion capacity. There is a substantial overlap with OSA as well, but OSA does not cause chronic hypercapnia. Because of substantial because of substantial clinical overlap, it is common for patients to exhibit symptoms of hypersomnolence, morning headache, fatigue, snoring, and nocturia. Nocturia is thought to occur because of an increased circulatory concentration of ANP, which is either triggered by atrial distension resulting from an increasingly negative intrathoracic pressure that develops when breathing is occluded during sleep, or from hypoxia-induced pulmonary vasoconstriction. Hmm. In either case, AMP inhibits the release of an ADH, leading to nocturia through increased excretion of free water. The diagnosis of OHS can be made in patients with BMI over 30 with documented alveolar hyperventilation while awake after exclusion of competing diagnosis. And it's not COPD often presents with exertional dyspnea and cough and wheezing, sometimes with resting hypoxemia. It is more common in patients who smoke cigarettes. It is not likely to present with daytime somnolence, nocturia, and daytime fatigue. COPD can be diagnosed using spirometry. Okay, next.
Okay. 37-year-old woman comes to the physician because of 1 month history of mid abdominal pain after meals. Mid-abdominal pain after meals. She has 10-year history of Crohn's disease, has recurrent episodes of abdominal pain. She underwent resection of terminal ileum and cecum 5 years ago, and two stricture, jejunal stricture plasties 1 year ago. Current medication include aminosalicylate. Her temperature is 101. Abdominal examination show moderate mid supraumbilical tenderness, moderate mid supraumbilical tenderness. There is well-healed surgical scar. Test of the stool occult blood test is negative, and upper GI series with the contrast show 10 centimeter segment of the ileum with irregular mucosa with no stricture. Which of the following is the most appropriate next step in the management? Mm, Crohn's.
Ready?
Is there any fistula? Is it fistulating
Why?
or it is acute? Okay,
Mm,
okay, give your answer.
Prednisone therapy. Prednisone therapy is the best next step in management of this patient with signs and symptoms of moderate to severe Crohn's disease. The clinical severity can be determined based on assessment of symptoms, which is in this case include fever, abdominal pain, both of which are consistent. Oh, she has fever. Consistent with moderate to severe disease. Disease activity is largely based on patient reported symptoms and is a spectrum from clinical remission to mild, moderate, severe, or communal disease. Patients with mild disease may have minimal weight loss but no systemic symptoms, while patients with moderate to severe disease can present with abdominal pain, GI bleeding, nausea, vomiting, fever. Communal disease is marked by presence of severe symptoms despite the use of steroids and biological agents, and it's often associated with complications including abscess formation, peritonitis, strictures, bowel obstruction. In addition to clinical severity, patients should be assigned to either low, moderate, or high risk group based on their age, extent of disease, and level of inflammatory marker, history of bowel resection, and intestinal manifestation. This patient with history of numerous bowel resection and mucosal irregularity on endoscopy should be assigned to the high risk group. For patients with symptoms requiring immediate treatment, oral steroids using either prednisone or budesonide for a course of 4 to 8 weeks is used, but these medications are typically only used as a bridge prior to initiation of medications with fewer long-term side effects. In this case, treatment with prednisone to induce short-term remission is needed. It's not A because bowel rest will be appropriate for patients with Crohn's disease presenting either with local peritonitis from a microperforation or with small bowel obstruction. While
Can you
this patient does have a fever, she does not have any symptoms to suggest any other complication.
can you read the option C?
Yep. It's not C because infliximab therapy is considered a first line. Wait, infliximab therapy is considered a first line choice for inducing remission in patients with moderate to severe Crohn's disease, especially those with fistula disease, although it's almost always used in combination with other immunomodulators such as azathioprine, methotrexate, 6-MP, mercaptopurine. Additionally, this medication frequently takes several weeks to work, and steroids induce remission of symptoms faster. It's not surgical exploration is not needed in this patient as she has no evidence of abscess, bowel obstruction, or complication that will require surgery. It's not cyclosporine therapy is sometimes used for patients with fistula in the setting of Crohn's. Although biological agents are typically preferred, cyclosporine does not generally induce remission and therefore should not be used in this case.
Okay,
So
okay, can you summarize?
so I guess for Crohn's, first you give prednisone and then you try all the other. Uh, the biologic agents that you know, the infliximab, azathioprine, all that. But for acute pain, you give prednisone first.
Okay.
So prednisone, biologic agents, nothing works, surgical exploration. Okay, next.
A previously healthy 37-year-old man comes to the physician because of 1 year history of intermittent burning epigastric pain, 2 month history of diarrhea. The pain is relieved by over-the-counter ranitidine. He passes 8 to 10 large watery non-bloody stool. Examination shows no abnormalities. Test of the stool for occult blood is positive. Upper endoscopy show duodenal ulcer. Upper endoscopy show duodenal ulcer. Which of the following is the most likely diagnosis? Yes. Oh,
History of diarrhea. Penicillin, okay. Mm, 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 mm. Mm. Mm.
multiple duodenal ulcer, isn't it? Like
Successes are lingered by lipoma. It's between gastrinoma and lipoma. I just don't remember what was. I know there was a mnemonic for lipoma. What was it?
watery diarrhea, achlorohydria,
What else?
watery diarrhea, achlorohydria. Uh, uh,
About
but
that's
in vipoma, you will not gonna find multiple duodenal ulcer on upper GI endoscopy.
okay. Then it's gastrinoma, I guess. Okay. Ready?
Yes.
This patient with numerous is gastrinoma. This patient with numerous duodenal ulcers most likely has gastrin secreting tumor. Gastrin is physiologically produced by G cells in the gastric antrum and functions within the gastric body to produce HCl. Zollinger-Ellison, okay, that's the word I was looking for. Zollinger-Ellison syndrome, the constellation of findings associated with gastrinoma. Oh, okay. Stems from a gastrin secreting tumor typically located within the pancreas or duodenum. Gastrin secreting, okay. It results in excessive production of acid by the gastric parietal cells. This can lead to recurring chronic duodenal and jejunal ulcers, which can present with abdominal pain, diarrhea secondary to malabsorption, and possibility of hematemesis, melena hematochezia. The initial step in evaluation of gastrinoma is to measure the serum gastrin concentration. If abnormal, a secretin stimulation test should be performed, which will disclose increased gastrin concentrations after administration of secretin, opposite of the normal physiologic inhibition. Okay. Cross-sectional imaging should then be performed to determine the location of the carcinoma for surgery. In the meantime, treatment with PPI is indicated to reduce gastric acidity. It's not E because lipoma is a rare tumor associated with men, multiple endocrineoplasia, that produces VIP. Through its physiological mechanism of action, VIP causes chronic and profound watery diarrhea, electrolyte disturbances, hypokalemia, hypercalcemia, hypochlorite, alkalosis, flushing, vasodilation, and hypercalcemia, but not duodenal ulcers. What is the mnemonic again?
So,
WH.
sorry.
The mnemonic for Vipoma is WH something.
What like WADA. WADHA. In the
WD.
you can find it in the first state.
Oh,
watery
so
diarrhea,
water diarrhea,
achloro
hypo.
hypokalemia, and achlorohydria probably.
Okay, perfect. Next.
Okay, I have sent you something uh, in the Telegram. Okay,
Oh, oh.
before jumping on that, I like I want to say, have you heard about the step three biostat? Like there are it is. I have sent you the offline version. Like there
Mm-hmm,
is question and there is an answer. Like there is near about 35 questions as far I
mm-hmm,
remember. So
mm-hmm,
that's good for only they this is only for biostat. Like
mm-hmm.
though it is step three, but it is related to our exam. And
Oh,
one of our mentor or one of our friend has told to do that. So just if you want to do, then we can do it together. You understand what I'm trying to say? Like we can
oh,
solve by together.
mhm. Oh,
Okay.
you want to solve it for step two?
Yes, you can
Okay.
ask your mentor. Like you can ask your sorry, you can ask your tutor that is it worthy or is it. If he permits, then you can we can do it together. If he not, then you can ignore. But I as far I know that that was good. You can see the questions.
I'm not able to open. It's just it doesn't open anything.
It's the rar
Wow.
file.
Yeah. So I, what does that
You
mean?
have to extract that file. Like rar file has to extract.
How do I do that
Y- Where yeah, where you have done. I can't
on my
see here.
phone? On my phone, I
Okay,
don't have Telegram.
you can download Telegram in the laptop, then you can do it easily. In the
And then,
phone you need to have the like WinZip or that extractor. You got my point.
okay.
So you can download the Telegram here.
Oh,
Yes.
I have Telegram. I just don't know why you always use it on my phone.
Uh, Oh, use everything in the computer. I know it is not worthy enough, but it is helpful.
Yeah.
Okay.
Okay. Try to open it later, and I'll let you know if.
You just need to what you need to do. You just need to scan that thing, and it automatically opens.
What do you mean?
Open your phone, just scan that scan, and
Mhm.
automatically it will open in the like just scan the Telegram. You got my point.
Yeah, I got it.
It's very easy.
I just did it with my phone, but it's not.
Just open the Telegram of your phone, go to the settings and device, and link to the desktop device. That's it.
Go to the settings and device.
Device and link to
Really,
the desktop device.
the
You found?
desktop.
Then
Uh-huh.
that's it.
Oh, okay.
Why you need to do all that?
Oh, man, I suck at these things.
I, 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 I'm trying to make you.
Like, I swear, I feel like since I met you, like I've been doing so many things that like the whole Telegram and the whole AI, and that I just don't. Yeah,
These things are helpful. That's why whatever I am using, I try to share you because I think that sharing is important. Like
yeah.
what I have know. If you know that thing, what will happen to me? My knowledge will increase. It will not gonna decrease. You got my
Mm-hmm.
point. So
Mm-hmm.
and what I try to tell you lots of things that because I want to memorize that things with you, and I
Yes.
try to create a memory like I have studied these things with you, so I can recall that. You got my point. It was my previous way of learning. I don't know people like it or not, but I like it.
I wish I had met you in medical school. Would have been so much easier. Because my medical school, nobody wanted to show nobody because then they feel like you will.
No, no,
It's not
just
it's
click
different,
the.
right?
You don't have extractor like RAR file reader.
I wish I don't have it.
Then you
Actually,
can. like you need to go to the app store and download WinZip or like that.
WinZip.
WinZip or WinRAR, this kind of thing.
Jesus. All right.
There is plenty of thing. There is like that one, the
Which
unzip.
one? Which one?
This
Unzip.
yes, this unzip. You can download in the RAR extractor. This all the thing, all the all the app
But
can.
this one is fine, right? The WinZip.
Yes, this one is fine.
Jeez. Okay.
Okay, now
So
go to that file.
this one.
Yes, just drop here. Yes,
Oh.
it's easy. You if you don't know anything, just ask me. That's the thing. Go to the number one, 1 to 5. Go
What?
one, one. This one,
This
one
one.
to five, 1 to 5. In the
This one,
middle,
right?
in the middle. Go to the middle first. In
Oh, this one.
yes, 1 to 5.
Okay.
One to
And I
five has two options. Like this is the questions, and next 1 to 5. Go to the 1 to 5. That was the answer.
this is the
This
question.
yes, this is the question, and the this 1 to 5 is the answer.
Which 1 to 5? There is no another 1 to 5.
Yes,
Oh,
there.
this one.
Yes, I don't know why it is not serially given in your laptop. In my laptop, it is actually serially given. You got my point. So
Yeah.
so that's the
Oh, so
thing.
I have to then download export it to my computer one by one. Or
Yes,
no?
just yes, you can extract one by one. Like we have done 1 to 5 questions. We can see the
Mm.
question first. After that, like what we are solving now. You got my
Oh, I
point.
get what you're saying. I get what you're saying. Okay,
Yes,
okay. So I will export the 1 to 5 question and answer, and then
yes.
we will solve it,
Then
and then I will
then
export it.
then I will go to the everything is serially given. Just you need to find it out. You got it?
Yeah, and then I'll do 6 to whatever the
Yes.
next one. Okay.
So
Okay.
I am emphasizing this because biostat is hard, and if we have the knowledge of step 3 also, like if you go through this question, these questions are pretty easy. Like these questions are related to step 2. When you go through this question, you will understand what I am trying to say. That's why the
Mm-hmm.
our mentor or our friend actually told me to solve it, and he actually shared this. I have
Okay.
lots of thing offline. That's why I share you.
Yeah, because my tutor, he told me, he was like biostat. He was like, as long as you do real work, you are more than enough. You have more than enough for the step two.
Sorry.
Yeah, because my tutor, he was like, because I was asking him, do I need anything else for biostat, and he was like, no, as long as you do all the you work for biostat is more than enough for step two. Yeah, that's what he was telling me.
In
And
this
the
part,
videos that
then
I
I'm
sent you,
not satisfied. Like biostat is very hard.
you are not satisfied.
True,
But that's
because
true. That's I
because
get
they
it. I
they
get it.
actually like the mentors actually do lots of things. Like they even if they can solve the ambush too, they actually don't share. Like lots
Have
of
you
people.
have you solved have you done ambos? The not all of it, but the ones
I
that the ethics
no
and the
no I
thing.
haven't done. I haven't done. But
Yeah,
our mentor actually told me to do that.
yeah, because I think I read already, like everybody does it on the
In
last week.
every Reddit post, most
Mhm.
of them have done the ambush.
Yeah, the
And
ethics one, the quality
the
improvement in ethics.
ethics one, and they
Mhm.
emphasize the CMS form. That's why I look for the CMS form.
Oh,
It,
so they said the CMS form is better than ambos for ethics. That's what they're saying.
no, no, CMS
Oh.
form is for everything. The
Hmm.
ethics is for the ambush.
Okay. Okay. Yeah, because I've seen everybody say that they saved that for the last week before the exam. They say, okay, I did like 1,000 questions of the ethics thing for ambos in the last week. Mm.
Okay, okay, let's
Okay.
do 30 up to 30. Okay,
Mhm.
A previously healthy 23-year-old woman who is graduate student comes to the office because of 4-month history of intermittent diarrhea characterized by copious loose brown stools and a moderate abdominal cramp. The cramps are relieved by defecation. She has not had fever, nausea, vomiting, weight loss. She takes ginger extract and daily multivitamin. She smokes 3 to 5 cigarettes daily. She drinks 1 to 3 beers on special occasions. She does not use illicit drug. She has not traveled recently. She is 5 feet 6 inch tall, weight 63 kg, BMI is 23, temperature is 99, pulse is 72, blood pressure is 112 by 68. Examination of the oropharynx and the abdomen shows no abnormality. Results of the lab are within the reference. Which of the following is the most likely responsible for these conditions?
Hmm. Hmm. What medication is she take? Ginger extra. Hmm. Laxative. Hmm. Is it laxative?
Loose.
Abuse
Is he
loose pills.
stimulating? Um, is he using something?
I feel like it's laxative, or it looks like
She's had
laxative.
trouble recently. Sorry.
It looks like laxative, but I don't know.
Or he is in celiac disease.
But
Copious loose
in the,
to moderate.
it says it like gets better when she defecates.
These things
Um,
looks like IBS.
it looks like IBS, but I don't know what's the mechanism behind IBS. Or maybe it's smooth muscle hypersensitivity. I don't know.
Okay, it may happen. The D, smooth muscle hypersensitivity.
Yeah, that's the
It
one.
may
Okay.
be IBS.
Yeah, that's the. I guess that's the mechanism. Okay, smooth muscle hypersensitivity is the most likely mechanism responsible for this patient abdominal pain and diarrhea, mm, which is most consistent with IBS. Okay. IBS is diagnosed using the ROM4 criteria, which include presence of abdominal pain at least once weekly that is associated with general relief by defecation, along with a change in stool appearance or stool frequency, at least 2 or 3 required. IBS is further divided into IBS with constipation, IBS with diarrhea, or IBS mix. IBS often present with intermittent abdominal pain that is relieved by bowel movements and associated alterations in bowel habits with intermittent episodes of diarrhea and or constipation. Features that are suggestive of underlying organic pathology rather than IBS includes presence of occurred blood melena, nocturnal diarrhea, ongoing diarrhea despite fasting, worsening abdominal pain, weight loss, family history of inflammatory bowel disease or colon cancer. While no consistent or definitive mechanisms have been demonstrated to account for all patients with IBS, it is thought that those with IBS may have an increased sensitivity to regularly secreted cholecystokinin, a highly sensitive gastrocolic reflex, and a higher rate of baseline peristalsis. Other theories, including the role of food sensitivities and mucosal inflammation, are being explored and potential contributing factors. And treatment often requires a multimodal approach with dietary modification, exercise, treatment of underlying anxiety or depression, and use of medications such as anti-diarrhea medication or antispasmodic medication. And it's not laxative use because the stimulant laxative use can cause chronic watery diarrhea in addition to electrolyte derangement, such as hypokalemia. But this patient does not report any history of laxative use. It's not celiac disease, which often presents with chronic diarrhea and weight loss secondary to malabsorption. Symptoms may overlap with IBS, but patients with IBS typically don't have weight loss. Okay.
Okay. A 82-year-old woman is brought to the emergency department by her family because of progressive loss of appetite and yellowing of the skin over past 2 months. She has 4.5 kg weight loss during the period, but says she feels well. Temperature is normal, pulse 100, respiration 12, blood pressure is 110 by 80, and supine is and while sitting is 80 by 60. The skin and the sclera appear yellow and dry. There is tenting over the forehead. The liver edge is palpated. The liver edge is palpated 10 centimeter below the right costal margin. Hemoglobin 10, serum bilirubin 3.4, direct is 2.2, ALB 500, and AST 70. Which of the following is the most appropriate next step in the diagnosis?
Direct. Okay.
Yes, postural hypotension. And there is sclera appear yellow, tenting forehead, liver is palpated. Direct bilirubin is ALB by obstruction. Okay,
Ready?
yes.
Hepa. Here. Hepatobiliary obstruction often occurs from malignancy, classically presented with painless jaundice and weight loss. There are many possible types, for example, cholangiocarcinoma, pancreatic carcinoma, hepatocellular carcinoma. Pancreatic carcinoma commonly occurs in the pancreatic head. It is often initially characterized by non-specific vague abdominal discomfort or weight loss. As the mass increases in size, it can lead to obstruction and dilation of both the common bile duct and the main pancreatic duct, referred to as double duct sign on imaging. Obstruction of these ducts can result in painless jaundice, prevention of excretion of conjugated bilirubin, exocrine pancreatic insufficiency, impaired digestion, and weight loss caused by prevention of excretion of pancreatic enzymes, or pancreatitis, activation of pancreatic enzymes. If the pancreatic adenocarcinoma continues to spread and results in infiltration of surrounding abdominal viscera or encasement of the adjacent neurovascular structures, this manifests with severe abdominal pain. The non-specific nature of pancreatic adenocarcinoma um, early symptoms create diagnostic dilemma because many benign conditions present similarly. It is frequently asymptomatic until it creates an obstruction. GI dysfunction, neural or vascular encasement, invasion, or metastatic disease. Initial diagnosis is made with CT scan of the abdomen, which can elucidate the cause of biliary duct obstruction and the extent of cancer, or competing diagnosis, hepatobiliary structure. It is not cholecystography is used to evaluate the gallbladder, which, when inflamed or obstructed, presents with wide open apparent pain, nausea, vomiting, anorexia, or diarrhea. It will not be the first choice diagnostic test to evaluate for obstructive disease. It's not a esophagogastritis. Where was I was looking for another? Okay, it's not esophago. No, I don't need to read that one. It's fine.
Esophagogastroduodenoscopy. Do you know
Oh,
that?
you wanna? Is used to evaluate for esophagus, stomach, and the duodenum, and can diagnose conditions such as peptic ulcer disease, esophagitis, esophageal cancer. This patient does not have features suggestive of any of these diseases. If obstruction is occurring at the duodenal papilla, esophagogastroduodenoscopy may discuss the diagnosis. But this not does not but it does not evaluate the biliary tree proximal to this structure. Ah,
Okay.
okay. Okay, we are